All right, let's grab our markers and dive right into this explainer. Today, we are absolutely crushing the pharmacology of hepatitis. We're going to use the confused neuron method, basically a whiteboard session, to break down exactly how to defeat these viruses step by step so you actually remember it.
But first things first, what is the real danger of hepatitis? I mean, it goes way beyond just feeling incredibly tired or getting slightly jaundiced. The ultimate stakes here are chronic liver destruction, irreversible cirrhosis, and hepatocellular carcinoma. It's a quiet killer, and we really need to understand how to stop it before the liver is permanently scarred.
Section 1. Intro, Patho, and Symptoms. Let's draw an arrow and jump right into the pathophysiology primer.
So, writing out our viral lineup, we've got hepatitis A, which is all about oral ingestion and causes an acute infection. Then there's hepatitis B. Now, this is a DNA virus that can become chronic and carries a massive cirrhosis risk. Hepatitis C is an RNA virus, and it also carries that heavy chronic cirrhosis risk. And while D and E are definitely hepatocyte destroyers too, only B and C are the chronic killers, where we have highly effective targeted therapies available. So that is exactly where we're going to focus.
Now, what's really fascinating here is the stark contrast between the DNA nature of Hep B and the RNA nature of Hep C. This biological difference perfectly sets up our drug targets. DNA viruses replicate completely differently than RNA viruses, which means our antiviral strategies have to be custom-built for each specific enemy.
Section 2. The Arsenal. Let's break down the mechanisms of action.
Imagine I'm drawing a giant red X right over the viral life cycle as we step through exactly how we block Hep B. First up, PEG interferon alpha 2A. This basically turns the host's own immune system into a weapon, inducing enzymes that just chew up and degrade viral mRNA. Then we have lamivudine, which competitively inhibits the viral polymerase. Entecavir steps in and competes for the viral reverse transcriptase. And finally, adifovir acts as a total roadblock, terminating the viral DNA chain elongation. Boom, the virus is stopped.
Okay, shifting over to Hep C, we enter the world of direct-acting antivirals, or DAAs. These things are incredibly precise. See, Hep C creates this giant polyprotein that needs to be chopped up to even work, and that chopping is done by the NS3/NS4A serine protease. Then you have NS5B, which is the RNA polymerase that replicates the genome, and NS5A, which builds this membranous web for viral assembly. Target those three exact spots, and you win the war. Now, remembering all these complex drug names can be an absolute nightmare, right? But the confused neuron method gives us a fantastic shortcut. If the drug ends in PRVIR, it blocks the protease. P for P. You probably didn't know that, did you? But it's that simple. So drugs like Simiprevir or Graziprevir, they're protease inhibitors. The mechanism is literally hidden right there in the name.
Let's keep that meme energy going because we have two more golden rules. If a drug ends in BUVIR, it blocks the polymerase NS5B. Think B for build. It stops the virus from building its RNA. And if it ends in ASVR, it blocks NS5A. Think A for assembly of that membranous web. So sofosbuvir, polymerase inhibitor. Ledipasvir, assembly inhibitor. Once you see the code, it's so easy.
Then there is ribavirin. This drug violently disrupts both RNA and DNA viruses. It is a true triple threat. It starves the virus by inhibiting GTP formation, it prevents the virus from capping its mRNA so it literally just falls apart, and it blocks the RNA polymerase. It acts as an absolute sledgehammer against the virus.
Section 3. The fallout. Let's talk side effects and warnings. Because every weapon has a fallout, right? Let's rapid fire through the heavy hitters. PEG interferon alpha 2A, it causes severe fatigue, bone marrow suppression, neurotoxicity, and this profound, exhausting flu-like syndrome. The newer DAAs are so much better tolerated, but their major flaw is severe drug-drug interactions through the CYP3A liver enzymes. And ribavirin, it causes a nasty, dose-dependent transient anemia.
Point an imaginary marker right at the kidneys for this next one. Chronic use of adefovir brings a major risk. It can utterly wreck renal function, causing significant nephrotoxicity. It is absolutely crucial to watch the patient's kidneys closely when they're on this medication.
And I cannot stress this next warning enough. Ribavirin is absolutely contraindicated in pregnancy, period. It has devastating teratogenic effects. Verifying pregnancy status is a mandatory, non-negotiable step before even considering prescribing this.
Okay, here's a really tricky pharmacokinetic trap that catches a lot of people off guard. Liposphere versus proton pump inhibitors, or PPIs. So liposphere actually needs an acidic stomach to be absorbed properly. If your patient is taking a PPI for heartburn, well, that raises their gastric pH, making the stomach way less acidic. The result? The absorption of liposphere drastically drops, and your hepatitis C cure entirely fails. Always check their med list.
Section 4, the battle plan. Time to write out our treatment algorithms. For hepatitis B first-line treatment, we are looking at peg interferon alpha-2A subcutaneously once a week, or oral entecavir or oral tenofovir once daily. Notice who is missing from the VIP list. Lamivudine and adefovir are mostly out of the modern first-line algorithm due to high viral resistance and lower efficacy. We only want the most resilient fighters on the front lines.
For hepatitis C, the treatment depends heavily on the specific viral genotype. We mix and match our DAAs to hit the virus from multiple angles, all at once. For example, genotypes 1, 4, 5, and 6 get lidapasvir plus sofosbuvir. Notice they're often co-formulated into a single pill for ease, combining an assembly inhibitor with a polymerase inhibitor for complete viral lockdown.
Also, imagine drawing a massive red X over interferon for Hep C. Pegylated interferon is no longer recommended for HCV. The new DAAs are so incredibly effective and safe that interferon's inferior efficacy and frankly terrible tolerability profile make it a total ghost of the past for Hep C. Science moves fast, and we leave the toxic stuff behind when we can.
So, we've covered the pathology, the mechanisms, the mnemonics, and the algorithms. I want to leave you with this. How are you going to use the P for protease, B for build, and A for assembly rules to completely rethink your approach to pharmacology? Keep exploring these pathways, master the logic, and I will see you in the next explainer.